Hey everyone, welcome to Women Wired for Wellness. I'm your host, Dr. Nisha Chellam. Today I am really excited to talk to one of my colleagues and friend, Dr. Achina Stein. She is a psychiatrist, and we haven't actually spoken much about mental health in this podcast, but this was so important. She's the author of the book, What If It's Not Depression? Now, those of you who struggle with what we call apathy, a feeling of depression, but you know it's not depression, but you feel there's something else going on, this is the conversation you want to listen to. Most folks who have depression go to their primary care. A lot of times they are given a medication to boost their mood, and temporarily, a lot of people do feel some relief, but very soon you come back to your primary care saying, it was great for a moment, but I'm still having this kind of depression, and you get an increase in your medication or you get a new medication added. But what if your condition is not depression at all? What if the treatment was all wrong? How do you get to know that? Well, this conversation is going to give you a different way of thinking, like all our podcasts do. So remember, this is not medical advice. This is really opening you to a new information or new way of thinking. And as always, make sure you subscribe to our YouTube channel, share our podcast, download it, so we can continue to bring this amazing content to you as the patient, to make you a smarter patient and make us better physicians. So we work together to change the system. So once again, without any further delay, let's listen to my conversation with Dr. Achina Stein. Hi everyone. Welcome to Women Wired for Wellness. I'm your host, Dr. Nisha Chellam. Today I have a very interesting guest. I've been wanting to talk to her for a long time, and she's a colleague and friend, Dr. Achina Stein, and she's an osteopathic physician, but she's also a psychiatrist. She's a board-certified psychiatrist, and she's been practicing for 25 years. Here's why this is important. Normally, being an internist, I worked with psychiatrists. Probably 50 to 60% of my patients have seen a psychiatrist for either depression, bipolar, or anxiety disorders, particularly anxiety. And one of the things I remember, the role of a psychiatrist was to change their prescriptions, add more newer medications. And they would see a therapist in the psychiatrist's office. And it just blew my mind that despite years of therapy, my patients still needed to be on medicines. So one of the reasons I am really having this conversation with Dr. Achina is she has a very different approach, which is why she gets on this podcast, because the focus is wellness, not management. That's where we're wired for wellness. How do you get to be well and not manage your anxiety for the rest of your life on medications? And really one of the, I was just talking to her before we started recording. We were a part of an accountability group in our something to do with functional medicine. And I remember she was talking about a patient's feeling disorganized, or something was going on in their brain, and how to bring organization. She was talking about a square dance. I can't remember. I don't know if you remember that particular conversation we had. And I said, a psychiatrist talking to a patient about how they can dance. And if somebody has gone to a psychiatrist, that doesn't happen in a regular psychiatrist's office. So I am really excited to talk to you about this. So let's begin by giving the audience a feel of your background, from a traditional osteopathic psychiatry to your journey as a functional medicine. First of all, why did you choose psychiatry?
Well, we're going back many years, Niche.
I
Many,
know.
many years. We're talking about 30 years ago, or 34 actually. So I
Yeah.
graduated from medical school in 1990. What's interesting is that everything that I learned in medical school, I loved. I wanted to do every
Yeah.
rotation, go into it with excitement, but it wasn't the thing that just made things click for me. And it was actually a struggle for me to get to through medical school because of the way I thought about things.
Mm,
In medical school, they teach you to think very black and white,
right.
and there's like only one answer. And if you remember, it was always multiple choice exams, and so I could find a reason why every single answer could be correct.
Yes.
So I would mull over it, but Gina, what's the best answer? It's like, but it depends. It
Yes.
depends on this, and it depends on that. If I had a patient with this, then it would be A, and if I had a patient with that, it would be B. Right?
Yeah.
so i
Yeah.
never so I always struggled with that. And psychiatry, it really clicked for me because you have to think in gray. I'm a gray area thinker. I could see solutions depending on what's going on in that person's particular life. And
But
that's
is that how psychiatry is? Because I didn't think it was gray when I.
Well, okay, I'm a dinosaur because I learned, psychotherapy.
Yeah.
Psychotherapy was a major part of my training.
Mm,
And we were taught how to do psychotherapy. We were taught how to interview in a compassionate way. We were actually tested on that as well.
mm-hmm.
So there used to be a time where psychiatrists had to do psychotherapy. So things have changed a lot since then, and I think it's a huge disservice to our field by not requiring that anymore. And I really think that even if you choose not to do psychotherapy, it has made me a really good diagnostician because I understand the layers of the mind as well as the layers of the body,
Mm,
through functional medicine. So functional medicine, I got like that because it's all these layers, right? You have to change the way you think about things
yeah.
completely. So in my opinion, a psychiatrist is well trained to be able to get the history that a functional medicine practitioner would get, because it's so much in line with how we glean information from the patient from a psychiatric standpoint, but it's the same method from a physical standpoint. And so I just got it. And so when I was in fourth year, it was actually my last rotation as a fourth year medical student, and I chose family medicine because I just didn't know what else to do. And then when I did my psych rotation, it's like, this is it. This is where I belong. I just
Yeah.
got
Yeah.
it. So
That-
yeah, it was easy for me it just clicked for me.
yeah,
Yeah.
that is very interesting, because I remember the first few years of residency, we actually had a video in the room with the permission of the patient to see how we spoke to the patient. And we would be, I had to watch the video again and see, like, times like we say things like, oh, you're a type 2 diabetic, you will be taking metformin. And all of that was Greek to the patient. Had
Mhm.
no clue what diabetes is. And so it was a very different time
Right.
when, as physicians, we were really graded and really taught that there is a specific conversation, and I don't think that's been continued. So that's interesting that you said, you were asked to interview in a very compassionate way. And the other part that is also very interesting about the psychotherapy, because I clearly remember this was not so many years ago. It's probably about 6-7 years ago. I did speak with a psychiatrist, and every time I spoke about, I would pick up the phone and say, "Hey, this particular patient is having an issue." The only answer I would get, "Let's adjust the limictal. Let's adjust, downgrade this. Let's do this." And I'm like, no, she's telling me a lot of stories that I feel like something more, we have to delve a little deeper. And that's when I realized the psychiatrist is only job is to make sure that the medicine doesn't kill you. and
Right.
adjust it to the point where you're able to be functional, but the therapist gets to talk to you. And then we have this new rule where your internist, your primary care, you can sign documents saying don't share any of my therapy notes with my primary care.
Right.
So suddenly I was disjointed from my patient, and really her medical issues or his or her medical issues is connected to the
Right.
strength of the mind. So what speaking to how that is different for you now that you practice functional medicine, and how did you make that transition? What was the bugging point? Like, you knew you had to do something different because you have a private practice at this point. You're not
Right.
working for
Right.
an organization.
Well, actually, even before I did functional medicine, I was a very different doctor than most doctors. I was one of those doctors that refused to do 15-minute med checks. I
Yeah.
thought that, to me, and I feel like that's negligence because there's so much I need to know and I
Yeah.
can't do it in 15 minutes. It's just, there's just too much going on and I needed more time. And so I would spend, so I was trained also under the approach of the biopsychosocial approach by Dr. Paul Fink. He's a psychiatrist. So in my day, it was extremely important to look at the biology, the psychology, and the social aspects and combine the two. And so since that time, there have been psychiatrists that have become just psychopharmacologists.
Mm-hmm.
And, so I guess it depends on where you got trained as to whether and how important psychotherapy was to you. And I was actually I was planning to be a psychoanalyst. I had gotten on the psychoanalytic track. I had 3 attendings that supervised me for psychoanalysis, and that was what I was going to do. And so, I rarely prescribe medications already, and I came off that track because life got in the way, and I had 2 children and 2 little kids, and it was just too hard to do both. It's like, okay, I got to get a job. So I started working in a community mental health center, but I always had that approach of talking about everything that was going on in that patient's life and coordinating and seeing how much of this was psychological, how much of this was biological, and how much of this was social.
Yeah.
They're in the environment that's being affected by people around them and their circumstances. So obviously in a community mental health center, these are people who are poor and they don't have a whole lot going on in their lives, or they have difficulty working, or they have family issues, toxic environment. So it's really it's looking at all of those layers. So I was already doing that.
Mm-hmm.
And my initial evaluations were already an hour and a half. That was another thing I insisted on. So I would really get a lot of detailed information. That was just the way I operated before functional medicine. And there were times where I would get stuck seeing patients and stuck is like why is this happening? Why is that going on? I would always have these questions and try to figure out the answers. And it just didn't come. I just didn't have the answers. And I started looking into integrative medicine alternatives, and that was when integrative and complementary medicine was getting to be really more popular and more acceptable, and going to conferences where they would talk about those things. And so I actually thought about doing a program out west with Andrew Weil, but because of the kids, I chose not to. And around the same time, my son had a mental health crisis. So here's a psychiatrist who has a son at the age of 14 who actually becomes acutely depressed and suicidal and standing on a 5th floor ledge, ready to jump. And that overnight. And it's like, oh my gosh, what is going on here? And the thing that the thing that was about him that made, besides it being just overnight, the thing that didn't make sense to me was all the neurological symptoms that were going on as well. So I always think about if I didn't have the neurological symptoms to make me think there's got to be something else going on, I wonder if I would have become a functional medicine doctor. It was that piece. He couldn't read anymore. He just couldn't read. And that year, at that year, I took him to a traditional psychiatrist. He got on meds. He was on 3 or 4 medications because he couldn't sleep. He was anxious, depressed. He got a little bit better, but he wasn't my son anymore. And he couldn't read. So that year we had to put all of his textbooks on audiobooks. We got the audiobooks of the textbooks and so that he could continue at school. And but that was the piece, like something else is going on and nobody was able to help me. And that's when I started digging. And it was because of that I found a functional medicine practitioner in a physician, MD physician. And I asked actually to shadow him because I was just so fascinated with him. And when I did, and his name is Ed Levitan. He has a practice called 5 Journeys in Newton, Massachusetts. And he at that time his practice was Visions Healthcare, and I shadowed him. It was so kind for him to allow me to do that. And I thought, oh my gosh, I have to bring my son here. And so long story short, he basically went through the whole 5 R's of removing, replacing, reinoculating, repairing, and rebalancing. And he was able to come off all of his medications, all of his symptoms remitted. And we learned that the reason he couldn't read anymore is because his extraocular muscles were inflamed, causing double vision. So that took about 2 years to go away.
Wow. So, I mean, when you say the 5 R's, people who are listening to this for the first time, what would you say was really, obviously there was testing that was involved.
Right.
And what did the testing actually show, and what is the 5 R as a solution?
So he had food sensitivity testing, and it showed that he had very high numbers, IgG sensitivity, which is for food sensitivity. IgE is food allergies. So he had high levels for dairy, soy, and gluten.
So it's a gut problem, basically.
Yes. Oh, so just what's interesting is that when you think your kid's healthy,
yeah.
But this kid had lifelong constipation, lifelong eczema. And this is a kid who would be on the toilet for a half an hour and everybody's waiting for him at the restaurant. Sitting on the toilet like a bird. And the eczema was so bad that when he was 4 years old, I would tell him he was part dinosaur because he was so into dinosaurs. And so that's how he looked like a reptile. I mean, and he thought that was really cool. He was like, oh, part dinosaur. So, it was really, and that was just what we thought was his normal. That was just the way it is. You're going to put lotions on your hands. You're going to get, his pediatrician wanted us to put him on laxatives, which we weren't going to do that, Yeah. So, but what's interesting is that when we pulled those foods out, those were the things that cleared up the fastest. Within a month, gone. The eczema and the constipation was gone. And that was his buy-in, which was interesting. And this is a kid who ate only white food.
Yeah.
Only white food, no vegetables. He would have popcorn and rice, tons of rice, pasta, tons of pasta, cheese, milk, tons of milk, like only white food, no vegetables. Except maybe broccoli. Actually, all 3 of my kids would eat just broccoli with cheese on it. And that was it. My other kids would eat more vegetables, but he just wouldn't. And so that was the thing that got better. But he definitely had issues with his gut, and he'd always had issues with his gut. But again, we thought that was his normal, and so we cleared up the gut by removing the foods, removing some of the pathogens that were found. I don't remember what they were specifically for me to tell you. So foods, we removed foods, infections, toxins, stress. So stress was also a big thing. He had, a lot of social issues at that age, which is really common. And then we replaced what was missing, all of those nutrients, because he doesn't eat any vegetables. So he started to eat vegetables. Like I said, he had buy-in right from from the beginning because of the clearing up of the constipation and the eczema. So eating lots of vegetables, we started off with shakes, green shakes, and protein green shakes, and he would do that, and re-inoculating the gut microbiome, with probiotics, and then repairing the gut lining, and rebalancing. He was in psychotherapy, to talk about some of the social issues, that might have triggered that. I think what really triggered it for him, because he's had the eczema and the constipation from such a young age, he was inflamed all of those years. And so it was puberty that triggered. So there's always this trigger. It was puberty. So that it happened during puberty because that's such a remodeling of the body that takes a huge load on, the immune system. So the body goes tilt when those kind of things happen. And so that's why it happened then.
Got it.
So he did very well. He did very well, especially because he had buy-in. He was gung-ho to make the changes. And so the depression cleared up very quickly. The anxiety cleared up, with also the psychotherapy, because it was social. Some of it was social related, and the sleep cleared up pretty quickly. And he did really well until college. So of course,
new trigger.
Yes, exactly. Well, not just the stress of college, but just, you want to eat what your friends are eating. You don't want to make a big deal about what they're eating and what you have to eat. And he was, I did mention, we found out that he had celiac disease.
Oh, wow. Yeah. That's a huge one.
Yeah, it's a huge one. So he was celiac, and so he would, and soy was a huge trigger for him. So all of his friends want to go to Chinese restaurants, so he would go, and he wouldn't make a big deal of it. But then it's staying up late at night, so the sleep goes out the window, the stress of exams. And so that combination, by the time, he was done with his senior year, he was toast. But he knew, the thing is, he knew what he needed to do to get back on track. And that's the beauty of it, is learning what you can do to get back on track, and the tools that he already had the tools. He just needed to implement them. Yeah.
So for you, that was a huge why, to learn a different way of thinking. So how did it impact your your role as a psychiatrist? Because you were seeing all these patients, you were already spending a lot of time with them. Right. You were actually doing something what most psychiatrists would not do, or would have not been taught how to do. How did functional medicine actually shift what you're doing? Because a lot of patients do come and tell me, I love my psychiatrist. I spend so much time. She spends so much time with me, but I still see them on 5-10 medicines and none of their diagnosis change. So what is that shift, that different way of thinking, actually brought into your career?
So I think, getting the details of the history, because I knew how to do that with the mental and spiritual pieces of that, because there's also a spiritual component that I guess a lot of psychiatrists also don't really include as well. And that's really important. But getting the history is so important to figure out where things went wrong. So finding all of those layers, and then seeing where that perfect storm occurs, that trigger of the immune system where everything just kind of cascades from that point on, is really important. So getting that history and connecting the dots for the patient. So it's really important to get the history on a timeline, and then connecting the dots for the patient, because then they see it themselves, like light bulbs go on, in terms of, oh yeah, that makes complete sense. And then they start remembering other things that kind of connect more dots. And so when you do that, that gets the buy-in for the patient, and then they're able to see, almost reverse engineer everything that happened. They're more likely to do what's necessary to reverse engineer. So that's one big piece. But I have I've changed the way I think about diagnoses.
Mm-hmm.
So to me, giving a diagnosis tells you what it is from a specific model, and that model is the conventional model, psychiatric model. But if you think about it, there's lots of models in terms in the psychotherapy world, right? There's Freud, there's Jung,
Yeah.
there's Beck, there's all of these models. Why can't we just have more models of a frame of reference, a frame of thinking about it? So it doesn't have to be just this one model in psychiatry. That I think we need to look at the limitations of the DSM and also the harm of the DSM. That's the Diagnostic Statistical Manual that has all of the listings of all of the psychiatric diagnoses that psychiatrists and therapists get their codes from.
Yeah.
That is really a way to convey information that those diagnoses are a list of symptoms that a person can have, that you can use to convey information from one therapist to another, to be able to enlist people in research so that you can, recruit certain patients with those criteria, so that when you do research, everyone understands who the patient is that meets that criteria, in order to do research, and it's validated that way. And the third reason is the second reason is for billing. Billing.
I think that was the first and foremost reason I always thought.
Right. Yeah. For billing. And the third reason is for, attaching a medication to an ill. Okay.
Right.
So the ill is that diagnosis, and obviously there's research done to see, which medications provide benefit, a significant difference, improvement for that person's diagnosis. But when it comes to functional medicine, I find that useless and almost even harmful, because we're not treating just the head. There is a body attached to it.
Right.
Oh my gosh.
And there's something above the head too, which is whatever you're exposed to, the exposome, which alters everything.
Absolutely.
There's a fourth reason also. I feel like I need to add this, mainly because I know you do a lot of prison work and I do a lot of jail work. Mm-hmm. It becomes their identity. The number of times patients will come and say, I'm bipolar.
Right.
And so I need this medicine. And it just, and a lot of times they've been using drugs. I said, were you diagnosed bipolar on drugs or off drugs? Right. Like when you're using, when you're high, everybody's bipolar. I think if you give me cocaine, I would be bipolar. Exactly. But it's just, people don't realize that this is not your identity.
Exactly.
But patients do truly believe it's their identity, right?
Unfortunately. So that's when I said that there's harm.
Yes.
It's because of that
yes.
You actually nailed it right on the head, because that to me is harmful. And so people want to know what they have.
Yes.
But as opposed to, why do I have it? And so functional medicine, that's what we go after, is, well, what are the processes that are occurring that created this situation in your body that's connected to your mind and spiritually within this environment, right?
Right.
And so I don't need a diagnosis. That the diagnosis, I want to strip them from that. And if you right. look at it as your body, this is something going on in your body that is also affecting your brain,
mm-hmm.
So software and hardware, right? Then you don't have to think about a diagnosis. The only purpose really for the diagnosis is to understand which medication to give, but also prognosis on some
right.
level. I mean, right. it does help to then know over time what to look for down the line, and what to watch for in terms of dangerousness, like major depression and the kinds of dangers of suicidality, obviously. So,
right.
so it's helpful to have a diagnosis in order to make sure that you can make acute emergency interventions when needed,
right,
and Um,
Understand where the
right.
where
Yeah.
this person could be
Right. The
with treatment,
prognosis
without
already.
treatment, whatever it may be.
Exactly.
Yeah, yeah.
Exactly.
Okay.
So somebody who's been diagnosed bipolar disorder, who's had a manic episode and has been hospitalized multiple times for that, you're going to want to be a little bit more careful than someone who's been given a diagnosis of bipolar and it's like they're not really, like, when you really look at their symptoms, like, that's sort of, sometimes these diagnoses are given because nobody knows what else to give them.
Yeah, that is
But,
true. And a lot of people don't realize that. We just say, it looks like more like bipolar, or could be generalized anxiety disorder, and it could be a combination of two.
Right.
And post-traumatic stress, and before you know,
Exactly.
you have a list of diagnosis because you don't fit into any one particular thing.
Right. And that's what we try too hard to do, is to put people in these holes and try to fit them in there. And so people get very frustrated when they're given a different diagnosis every time they're seen.
Yeah.
And so, I've been told that I'm schizophrenia, and now I'm told I'm major depression with psychotic features, and now I'm told I'm schizoaffective disorder bipolar type. Which is it?
Yeah.
And then oh my gosh, what really kills me, we were actually trained. I had fantastic training, but there was one thing that now I think, oh my gosh, I can't believe we were told this, that if you have 3 to 5 diagnoses, on axis 1, I don't know if you're familiar with axis 1, which is the primary diagnosis. Axis 2 is personality disorders.
Yep.
Axis 1, if you have 5 diagnoses, then it must be axis 2, which is a personality disorder. And that's just so not true. So when a person tells me that they have a particular diagnosis, I go to, well, show me the money. I mean, really, tell me what symptoms you're actually having.
Right.
When did you have them? Give me and sometimes people come and say, I have OCD, when they really don't. So they self-diagnose a lot of the time. So, because people are so focused on, what do I have? What do I have? And so I try to move away from that and focus on the why. And ultimately,
and also how, probably, right? The evolution and the how,
and the
like,
how.
not only and the how. Yeah.
Yes, absolutely. So, ultimately what I do is I really just focus on the gut, because everything does start in the gut. 80% of the serotonin that your brain needs is made in the gut. So go ahead.
So if I can ask you this question, because this is important. When you look at the CDC, when they put out the stats, they say 67% of Americans are depressed, and only less than 50% take medications for it, right? Truthfully speaking, if you applied functional medicine, like you said, you're working from the inward outward, like from your gut, the connection to the mood, what would actually be the percentage of people having true psychiatric disorders? What would you, I don't know if there's been a study out there in functional medicine, but would you say, like, with the amount of resolution people can get, what would you say is the true percentage?
Well, it depends on how they got that statistic, first of all, right? So, I mean, I think if they did
survey kind of a thing.
Yeah, like what was that, the PHQ-9?
Yeah.
That primary care physicians are trained to do. And then if they've used that, then I would say a lot of people would come up positive on that in a primary care physician's office, because it is skewed to try to screen that and apply medication, right? So if they use the Hamilton Depression Scale, that I think is a little bit longer and a little bit more specific for specific symptoms, and that's probably a better indicator. But that being said, I mean, I'll just speak about my experience.
Right.
That many people are given a diagnosis of depression, and it may not necessarily be a specific major depression diagnosis or dysthymic disorder diagnosis, which is a more chronic depression, because they're presenting in such a way that they're not feeling well. and they might have brain fog, insomnia, fatigue, stressed, maybe a little teary, having lots of issues, that they're just not getting ahead, those kinds of symptoms. They go to their doctor. The doctor, might they might do some blood work, and then they'll say, "Oh, your blood work's all normal. You're probably just depressed, and
Right.
here's a prescription." Right? That, to me, that is not an appropriate person to give a prescription for. Because that is the kind of person who could easily get well if they did a functional medicine approach, because they're on the milder side. In fact, the research shows that antidepressants do not work for depression on the mild side. In fact, you have more benefit from exercise. So lifestyle changes automatically, would be the treatment of choice, in my opinion. So, mild depression is not going to remit at all with an antidepressant. And then there's, you have to weigh the benefits versus the risks. There's lots of risks to this. But oftentimes the diagnosis of depression is given, and a prescription handed to the person because they don't know what else to do, and they don't have time.
Right.
They don't have time. They might think of referring to a therapist, but then getting into a therapist's schedule. So they want to give something.
Yes.
Want to give
put out the fire.
To put out the fire. And I personally don't think that's the most appropriate. I think it needs to have further investigation in terms of, is this a moderate or severe depression? Is this, they'll probably do screen for suicidality.
Right.
But in a 15-minute session, I'm sorry, most people are not going to say that they're suicidal. I think you just need more time, to be able to really discern what's really going on. And so many times people go home with that prescription and just throw it out. It's why I wrote my book, right?
Yeah.
What if it's not depression? That is the person to whom I wrote this book.
Yeah, just so for the people to understand, the questions your primary care asks is, in the last 2 weeks, have you felt hopeless, or have you thought about killing yourself? Something to that effect.
Yeah.
I don't even ask those questions anymore, but you're asking those two questions. And if you say yes to both, you're like screened for depression. Even if you say yes to one, you're depression. And then you get put on a medication. You may be told, go see a psychologist, and most psychologists are booked for weeks together. The other part that is very important also in what you say is, when somebody is like the borderline mild depression, and they actually check one of the two tests that we were as internists told to check, B12 and thyroid, right? We check both of those. They're within the range. And now I'm not even checking T3, T4, none of those, no extensive testing. I put somebody on an antidepressants. Many of these antidepressants actually will create further hypothyroidism because they prevent that conversion to the active hormone. And the person actually initially may have a blimp, like, I feel better, and then they become more depressed.
Right.
And so what you're really saying is, some of these things are not depression, but there are other reasons why your mood is affected. Right. And besides just those two blood tests, there's a little more digging deep that we could get to do. Right. So why is it not depression? What if it is not depression? What are we missing?
Well, there's, one of the things that the DSM, the Diagnostic Statistical Manual, indicates is that one of the criteria is, believe it or not, is to rule out a medical cause. You should not give a diagnosis until all medical causes are ruled out. Right. And that doesn't really happen in very much as much as it should. It really need further investigation. And I think the difference between the conventional world is that there's like 5 tests that are drawn, and there's not enough clinical history to figure out what else it could be. But there's all of this other tests that could easily be done, but they're just not to rule out a medical cause. So there's lots of things that can cause inflammation in the body. So I've just from getting a clinical history, I've been able, and for people who've had major depression, I have been able to say, I think you have Lyme's disease just because of the history, and because of digging and digging and digging, and no one's tested them for Lyme's disease, and then they get tested and voila, they have Lyme's disease. So, mold toxicity can cause us very severe depression and anxiety. So having a C. diff infection, a Clostridia difficile infection can cause not only depression, anxiety, but also psychosis, because it inhibits dopamine beta hydroxylase, an enzyme that converts dopamine to norepinephrine. So dopamine goes up, 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 and norepinephrine, is not made. So there are nutritional deficiencies. So the way our
which we don't check for. I mean,
which we don't check for.
We don't check for any of these things. Whatever you said.
Right.
In fact, Lyme's is not even a disease in traditional medicine, right?
Right.
Mold toxicity, forget about it. That doesn't exist. So you're really looking at something that is not mainstream and will never be done in mainstream medicine, because again, there is the genetic interaction with your environment. I don't think as physicians, and a lot of us in functional medicine, we realize the more we know, there is more to know.
Exactly.
Right?
Oh
right.
My
But whereas in traditional medicine, it's a box. Like you said, there are several models. So we choose a model. This has been my way. And the only thing I'm getting updated on is the newer surgeries and the newer drugs.
Right.
I'm not getting updated on a different way to look at this disease process. Right. So what you're bringing is, what other sources are there that can be actually addressed, reversed? So not only we're managing the disease, we're actually trying to eliminate this condition. Correct? Right. Am I getting that right?
I mean, there is complementary medicine techniques. There's psychiatry. There is actually a group associated with the American Psychiatric Association that does complementary psychiatry. There's a new field called nutritional psychiatry, so treating.
But that should not be complementary. That should be
the way. Oh yeah.
That should be the way. Yeah. Why is it complementary? It's not complementary.
It shouldn't be. That should be the way.
Medicines should be complementary. Right. Right. When all this fails, we add medicine. Yeah.
Right. So medications, in my opinion, should be a last resort. I still prescribe medications.
Yeah.
I mean, totally. But it should be a last resort. It should be given to people who are acutely psychotic, acutely manic, acutely depressed, and unable to function, or are in danger of harming themselves or others. And sometimes they require hospitalization. So there have been situations where people don't want to be on medications, and it's like, you know what, we're at a point where we really need to be having you on medications but I'm able to explain why, and it's always the benefits versus the risk. So, if you're able to explain why, you need to be able to take these medications in order for you to function, but also be able to do the work that's necessary, because doing functional medicine is work on the patient. They have to make changes. So sometimes something's going on in the gut that's taking really long time for us to rectify and bring back into balance. And so, that would be a time to take medication. So, a major root cause is just inflammation in the body. So autoimmune processes cause inflammation, not just for that specific area, but it does affect the brain. So,
right.
Yeah.
So when folks are struggling with all these multiple diagnoses, I think this has been me as a primary care, the bigger challenge has been you as a psychiatrist is the professional who can actually tell a patient, right, you have a diagnosis. And how do you actually, like somebody comes to you with like 3 different diagnoses, right? Mm-hmm. They've had a rough life. And this is something I tell my patients, your life is broken, you're not. We just get to use those broken pieces to build something beautiful for the future. But when they come to you and they say they have all these diagnoses, how do you help them understand that there's a different way? What do you think is the biggest stumbling block for them to realize that this is something that doesn't require just a diagnosis and a medication, but something that they can actually resolve? Do they already come to you with that feeling like, there's a different way? Or they come to you because somebody referred them to you? And how do you approach somebody who's just like completely clueless that there's a different way?
Well, I if someone calls me and they have no idea what functional medicine is, I'll usually have them read my book. So they can download my book from my website for free as a PDF.
Okay.
So most people won't come to see me because I don't think it's a good idea for them to, because it is a lot to understand. It's a completely different model, and it takes a while to wrap your mind around it. So I think it's better to educate yourself first about functional medicine. And then once they get it, like the light bulb goes on, it's like, this is exactly what I want to do. I didn't even know it existed. But there's always going to be that person who wants to take medication, and that's the way they want, and that's fine. Yes. If it works for them. But there are a lot of people who where it doesn't work for them completely, or they have side effects, or it poops out, or they just don't want to be on medication, right, for lifelong. So I am, I tell people that the diagnoses, they might have a diagnosis at one point in time, and then it might change. People evolve. They're not the static person. Yes. They're this dynamic person that is evolving over time. Some of those things, unfortunately, stimulant medication that are given to children can actually trigger a manic episode. Antidepressants can trigger a manic episode. So what's unfortunate is that instead of saying, oh, it's a side effect of the medication causing mania, the diagnosis is changed. And then a medication is added. That's unfortunate. That's what happens, unfortunately. But because you're using these powerful medications that affect the brain, right. It's changing stuff in your brain. So but over time the diagnosis can change because the person changes, and it's only a cross section in time. But sometimes people do have the same diagnosis over time, and they get better, worse, better, worse, better, worse. So it's only a way to convey information. I don't think people should take it as that's their label, and that is their label. Yeah. I think that's important. The other thing I tell people is that, just like a picture is a picture is like better than 1,000 words. Yeah, something like that. It's worth 1,000 words or something. Yeah, it's like, to me, your diagnosis is gleaned by the information that you provide. Yeah, that's true. And so as time goes on, there might be pieces of your history that you didn't provide, either because you didn't want to, you didn't trust the person, or you didn't feel comfortable, or you just didn't remember, yes. You just didn't remember at the time. And so that's why it's always important to go back to the drawing board if something's not working. I think it's important for all practitioners, psychiatrists, therapists, whatever, to if something's not right, I go back to the drawing board. It's like I missed something. There's something you're not telling me, or didn't tell me, or didn't remember. And I just know it. And sure enough, because there will be something that in my mind, it just like things click. There's, I get this sense like there's a hole here. I don't know what that hole is, but let's go back to the drawing board. Like if something's not clicking, then I start from the beginning. It's like, you told me this, this, and this, and is there something else going on around this time? And it's like, oh yeah, that's right. So it's kind of amazing, and this, to be able to do that. But I think you have to remember that it's only as good as what the patient tells you. And so one piece of information can really flip that diagnosis. And it also is also important for patients to realize this is why every time you see a therapist and a psychiatrist, you're telling the same story, but the person asking the question may ask it a little differently. Right. So, and that's, I find that too, a psychiatrist did not
ask a specific question, did not get a specific answer, but a medical student walked in and it's a completely different story. We've seen that happen several times
Oh,
because,
absolutely.
yeah, they're asking little deeper questions about this specific condition. So don't get tired that you're being asked questions. We're all trying to get to a root cause, particularly when you go to a functional medical doctor's
Right.
office. A big portion of this is in filling that history form or having the chat with the doctor about your evolution. Like you said, I like the word reverse engineer because that's how most problems are solved.
Right.
Is let's go upstream and see what caused this problem to begin with and then rebuild. So when patients come to you, what is the percentage of patients who you feel like in your small practice, because you're thinking differently, you're looking for different things? Would you say like 50% of the patients you find a different cause that is affecting their mood, or is it more?
Ooh, well, I see all sorts of patients, not just, because
Yeah.
I'm like there's very few functional medicine practitioners
In
in
your, yeah,
so
yeah.
I have a lot of people that come to me who don't even have mood symptoms, or so they know what functional medicine is and they like the approach, and I kind of treat a lot of people that come to my practice. So out of the people who I do see for depression and anxiety, I find that if it's a mild depression and a mild anxiety, like we talked about those
Yeah,
categories, and it's within the let's say the last couple of years that they've had it, I find that they have complete resolution of those symptoms.
that's true.
Complete,
Yep.
complete
Yep.
resolution. So it's those people who have significant symptoms of depression and have been like a decade, let's say, and they have a significant morbidity of their physical symptoms, then they take a lot longer, because a lot of times they might have, let's say, small intestinal bacterial overgrowth, or severe IBS, or like I said, an autoimmune process happening. So there's other conditions that can occur. So Lyme's disease with co-infections, or mold issues. And so it's looking for these other things that might be going on that could be impacting on their mood. So when it becomes more severe, and the other piece of it is trauma. So
Yeah.
if someone has a significant amount of trauma, so I use the ACE score, which is the adverse childhood events, as part of my intake. So if trauma is something that absolutely can cause difficulty in doing that reverse, because if you're always in fight flight, if you're always hyper vigilant, always in this place where you are feeling unsafe, it's going to be very hard to calm down your immune system.
Correct.
And so it's those people in that category as well that it's going to take a lot of work to calm their immune system down from a psychological standpoint, because you need to be in what we call parasympathetic mode, which is the rest, digest, and heal mode, in order for you to really affect a significant change. So that's when you really want to start with meditation and yoga, and there's all of these other modalities to try to calm down the system. And so I find those are the people who have to be in psychotherapy on a regular basis, and most likely will need medications in those situations. And they usually come to me on medication already. So, but then we do the functional medicine piece. But it's helpful. It's really helpful to, again, lay out all of the pieces and let them see how much of an impact that is and what they can do to affect the change. Not that it's not going to be hard. It's going to be hard, but there's so many things that they can do, and they're more likely to have buy-in in terms of doing meditation on a daily basis. and really working to find meditations that are in alignment with where they are,
Right.
and so if one particular type of meditation doesn't work for them, it's trying to find something that is in line with where they are right now. So that person that's the Energizer Bunny,
Right. Right.
that can't slow down, or I have to look at that can't slow down as not able to slow down because it's protective. They have to keep going, because if they did and they were able to be aware of some of their emotions, that would freak them out. So
Right.
slowly, you got to be where they are. You have to be where the patient
Yeah.
is.
And peel the onion layer.
Yes,
Yeah.
yes,
Yeah. And
absolutely.
I think what you're trying to say, if I have to just simplify the process, because from an internal standpoint, you said it first. You said hardware and software. The hardware is how you're wired. And in my practice, I call it like the beliefs, biases, and bullshit, right? The belief is what you are raised with,
Right.
whatever your parents taught you, your teachers have taught you. The biases are your experiences, because this happened, therefore this is how it is. And the bullshit is the story you tell yourself
I
around
love
those
that. I didn't
experiences,
steal that
right?
from you.
Right.
I love
No,
that.
it is. So what you're trying to do is you have to be ready to change that story. But
Absolutely.
what you can change is from your experiences, kind of alter your beliefs. And a lot of what you do is giving them the tools, saying, hey, these are 100 things that have gone wrong or are going wrong, but 80 of them you can actually change,
Right.
which would be your diet, your sleep, your meditation, your relationships, your job. I mean, there's so many things you could actually change, but it is overwhelming, but you do it step by step. There's 20 things you may not be able to change. We'll get to it after we change this 80, because the whole relationship would have changed. And before you know, that journey to illness that you made, we can reverse engineer and make a journey back to wellness.
Right.
And it's just having that patience identifying. And I think a psychiatrist like you can help them identify where they take their power back to shift
Absolutely.
what they can do, right?
Absolutely.
So it actually, from a traditional standpoint, once you have a mood disorder, that's a lifelong label for most people. But from a functional medical approach, you're trying to see, can we temper it down, and if possible, get rid of it. And for everybody, that journey looks different.
Right. It does.
Right. Yeah.
Absolutely. Yeah. Yeah, it does. So it is different for everybody. And that's why the treatment plan is going to have specific interventions for that particular person. And it's matched to their personality as well as where they're at right now. So, people will start in different places based on where's the low-hanging fruit to start with, right? To start there so that they start having successes early on, and that allows you to keep going, because wow, I did that.
Yeah, they actually change for the first time in their life. They feel in control.
Yes.
Yes.
Yeah. It's pretty amazing. I actually had a patient who saw me for panic attacks.
Mm-hmm.
And that was his goal, to get rid of the panic attacks.
Yes. Yeah.
And it was interfering in his ability to do his job. And I'm just gonna take a
Absolutely. Yeah.
So what's interesting is that he had a history of being raised by a single mom, didn't know his dad, and he just had a very isolated type of childhood, and not really connected emotionally to his mother, and kind of just went through life and felt sad most of his life. And even though he was married and had 2 children and had a very fulfilling job, he still felt really, really sad. And he just chalked it up like, oh well, that's just the way it is. I'm never going to feel joy. I mean, he just didn't know what joy felt like. And so we worked to clear up his, did the 5 R's, the 5 hours of gut restoration, through the IFM and the Institute of Functional Medicine, for functional medicine is what it's called. But so we did the 5 hours, and his panic attacks went away. But a few months later, after he was, after we did that, and, a few months later, he called me up and he said, I've been experiencing, a difference in my mood. And it's like,
he's happy finally.
He's telling me what he was experiencing. And he goes, is this joy? I think I'm experiencing joy. Like, he had no expectation of going away. No expectation.
Right. Yeah. See, that is so powerful, because though that his bullshit had a very strong root, right? That's his story. Right. And to uproot that, you needed to make changes to his software.
Right.
The program that ran was completely different.
Right. My experience has been, and there's nothing written about this anywhere, and I'm sure no one's doing research on this yet, but I find that, so I do psychotherapy as well with some of my patients, but I also have obviously a lot of patients that see me for the functional medicine, but they see psychotherapists. Right. And I had one patient who was seeing a therapist for 4 years, and they kept going around the same loops over and over again, same loops. And then she did the gut treatment with me. And she came in one time and said, I'm starting to make connections in my therapy, and things are changing. Like, I'm figuring things out. It's all happening. Like, it was just really, So, and I see that happen over and over again. I have patients that come in when they start, they're very irritable and angry and frustrated. They have low frustration tolerance. They snap at my poor office manager. And like 3 to 4 months later, they're like the nicest person in the world. Like, so personalities change. Right. Just from doing this. It's amazing. It really is amazing. Yeah. So and it's like long lasting too.
Right. Basically, you're removing clutter. You're removing clutter so they can actually breathe. And most people don't realize when you're piling, this is another, a lot of this, the biases, belief, and bullshit, obviously I got it from somewhere. I just don't know where, but it stuck in my head. But I do have a life coach who told me this: don't frost your shit.
Yeah.
It's still, you flush the shit crap down and enjoy the frosting. But most of us frost that. Oh. And that's one of the reasons, I think, when you give medication, you're just frosting the shit. Right. And so it doesn't last. The stink is still going to be there. And how do you get to it? And I think a lot of people really need to understand that there is a different way. And as we, I'm sure we can talk about this a long time, but I want to just get into that one little thing that everybody talks about. People who get into this functional medicine, and you do mention somewhere people get confused about holistic and they take supplements, is the big question about the MTHFR. Right? There's a lot like, I have an MTHFR mutation, therefore I need to be on da. What has been your approach with that? And would you tell people when they have a genetic trait or a mutation, how do you approach that?
Well, it's important to know that specific one, but you can't put all your money onto one gene.
Yes.
It's just one gene that's part of this whole system of genes for methylation. So I try to explain that to people, that you want to do more extensive genetic testing and get the whole picture, not just that one gene. Right. So if you do have a SNP, which is a small nucleoside
polymorphism.
Polymorphism, that's it. Yeah. I'm getting tired, I'm sorry. So it's if you do have it, certainly you want to make sure that you take methylated vitamins, folate, and probably even B12. But that's a different gene. Yeah. But even so, there might be the ability that you might have that gene that kind of is less efficient in utilizing folate. but that doesn't mean that you are folate deficient necessarily.
Right.
So you want to look at other markers like the homocysteine level to
Yes.
see where you're at in terms of whether or not you actually are,
Deficient.
and
Or you need to bypass
right.
that.
Yeah,
Yeah.
exactly. So I think, and certainly people should not just take methylated vitamins unless they know that that they have that gene.
They need it also. I mean, the question is,
Yes,
do they need it? Yes.
exactly, because
Yeah.
you can actually get over methylated and
Mm-hmm.
cause more problems. So you do have to be careful. So it's not looking at that gene in isolation. You absolutely want to look at it in connection to all the other gene SNPs that you want to see and treat the whole picture, not just one piece of it. So I often get the homocysteine level and the methylmalonic acid, which is a marker for B12.
Yes.
And see how that's connected, but and that would be just as a screening piece right now in the beginning. But ultimately, if I'm really concerned, I will do genetic testing. But I don't think you need to do all of that up front.
You're
I
right.
think I would treat the gut first. I always treat the gut first.
Yes.
But I mean, unless they're in this immune overload and they're reacting, you really want to calm down the immune system first, because
Right.
treating the gut can also cause inflammatory reactions. So you want to calm down the immune system, go through the 5 R's, and then I use the SNPs to fine tune what's going on.
Mm-hmm.
So, to fine tune certain things, but I often find that I don't need to do that. I used to do genetic testing on everybody.
Mm-hmm.
I just find I don't need to do that often. And it really is for those people where I'm really scratching my head and like we haven't gotten anywhere, but I feel like there's so much to do even before that happens.
Got it. Got it.
Oh.
So somebody listening to this conversation has been diagnosed with whatever, mood disorder or a diagnosis like depression or anxiety or, schizoaffective or personality. What would your advice be? And they feel stuck. I think most people who come to doctors like you and me are people who feel there's more. They feel that there is, or they've heard from someone else.
Right. Yeah,
What
they're
would
not
you?
satisfied. They're not satisfied with the answers that they're given. A lot of them.
Yeah, and they're not satisfied with where they are in life, right?
Right.
What would your advice be to them if like all of this information is new and overwhelming? What would you tell them to do? Besides, I think your book is a great place for them to start.
Right.
And if you could give us the name of the book again and where they can go to get it.
Sure. It's What If It's Not Depression? Your Guide to Finding Answers and Solutions. You can buy it from Amazon Kindle for $6.99 right now. And but you could, if you want to get it for free, you can go to my website at it's Functional Mind. It's www.f as in Frank xnmind.com. And you can download a PDF of it. But I encourage you to get the Kindle because you have all the links, hyperlinks in the Kindle version. So then I give a lot of resources. And so to me, knowledge is power. It's the reason why I wrote the book. It's for that person who's not familiar with functional medicine and is not wanting to fill that prescription that was given for many times a wastebasket diagnosis of depression and or anxiety, and it's really understanding what is going on in the body and how and why. And so that I think knowledge is power. I think you need to educate yourself and be familiar with a different model of approach that works for a lot of people.
Yes.
And you feel empowered and you don't feel like you have this label,
And be a passive, I hate to say passive patient, but you're almost a passive specimen,
right.
In your own care. And that doesn't need to be that way. You can actually actively participate. In fact, you can drive your care when you
Absolutely.
have that knowledge,
Right.
right?
Yeah,
And
and we're partners in your care. So I would, I walk you through what you need to do. It's work. You have to be willing to do the work, but
right.
there's definitely many rewards. And most of my patients feel better. Um, yeah.
With time. So really one of the reasons I do these interviews with other functional medical doctors is most of us have come from the traditional background, and we realize that it has rules, it has regulations, and everybody needs to fit into that rule and regulation. It's just like how the school system does not work for every child, and the financial system doesn't work for every person. The medical system, if the current medical system is failing a person and failing you as somebody who's listening to this, open your mind to the fact that there's a different approach, and a different approach which gives you more control, more understanding, and the tools. Like you said, your son went off track, but he knows what to do. That's because he's understood his body really well. And for me, that empowerment of the patient, first of all, enhances our relationship with them. I mean, I look forward to going to work and talking to a lot of my patients. When I see them on the list, I'm like excited because I want to see what new things have they
Yeah.
discovered about themselves. What new things am I going to be able to provide? It's a completely different mindset, even for the physician, whereas traditionally what I used to look at my list and I used to sigh at, like, can I get done with this day, because I'm looking at people who are inflicting, without their knowledge, not to blame them,
Right.
a lot of pain on themselves. And here I have been given just this one tool, like, it's not a nail, but I've been given a hammer,
Right.
that medicine, and say, this is what you get to take. And I'm not succeeding, you're not succeeding.
Right. Right.
And that difference, I think I want people to really understand. And
Absolutely.
I think you've really given a very quite a few examples. I mean, somebody who has never understood what joy is.
Right.
I mean, not even, that's tragic, but at the same time, that's a great ending to this journey of discovering what is important to him, right? That's
Yes.
really amazing.
Oh, absolutely.
Yeah. Is
Yeah. And then
there,
yeah.
yeah, go ahead.
And then, when people have those experiences, then they tell other people. Like most of my
Yes,
practice is word of mouth. So
that's true. Most of us, I always say 80% of my practice is because of patients who talk about our practice to someone else. But is there anything that you wish I had asked you but I haven't asked you?
um yeah, I think I wish that we had a society that embraced new ways of doing things rather than calling it quackery, or that doesn't make sense, or that's not true, or just invalidating. There's a lot of my patients won't even tell their conventional doctors that they're doing the work that they are with me.
Right. Well, we're like that clandestine relationship that
I
they have
know,
with us.
exactly. They don't,
Yeah.
which is unfortunate. I mean, I don't think that's in their best interest. They should, and I encourage them to, but a lot of them don't want to get into it because then their conventional provider, basically shames them,
Yes.
and says that they're stupid, or, you're being taken advantage of and things like that. But nevertheless, I've one patient, it's like, okay, that's your opinion. I'm getting better. So
Yeah.
and the shame of that is that if they do get better, then they'll just assume, well, you're seeing a psychiatrist, of course you're going to get better, so and
Yeah.
it's not because it was really happening in your body. That's a shame. So I wish to see a change in our system where we have people like naturopaths on the front lines, because naturopaths, what we're doing is naturopathy. I mean, naturopaths have known to do this work before we did in functional medicine. They should be the front line for the milder, symptoms of depression and anxiety, and be the first line. And if I remember correctly, I think Scripps Center is actually in San Diego, is set up that way.
Yeah.
And then to have have nutritionists and health coaches working with you to make lifestyle changes with those naturopaths. And then the next step would be us as functional medicine doctors to really handle the more moderate to severe cases. It needs to be a team. We all should be working together and using acupuncture and using physical therapy and using osteopathy, craniosacral, and being able to refer freely within a system with the goal of wellness, and not just suppressing illness.
Right.
I wish we could see. I hope to see that in the future. And there are models around the country that are moving in that direction. And I just hope someday that there's a change in terms of our legislation, and our food system has to completely change. A
lot of money is involved, right? A lot of money is involved in all of this. And this is also something that I read somewhere. Whenever there is human suffering, if you go upstream, there's money involved. So the change actually doesn't come from the system. I don't think any system has actually changed. It's individuals like consumer who's consuming, who's, I feel, to some degree, victims of a system. When their demands change, the system adapts.
Absolutely.
And so a lot of our the podcast, the reason I do this podcast, this takes a lot of time and money for me, and I do it as a free service because I feel once we educate the consumer to ask the right questions, think a little differently, they will be able to change the system which has trapped us and them.
Yes.
And I really appreciate you coming on and contributed to this journey. And if there are any questions, make sure you comment either below the podcast or reach out to Dr. Achina. And what is your website again, Achina, so we can get that also
posted? You can Google functional mind, or you can go to www.fxnmind.com. fxnmind.com, and it's and I'm trying to think of anything else that you need to know about me.
And your Facebook page, do you have like a Facebook or a Twitter or?
Because I'm low in staff, we had to sort of I haven't been posting lately, but I do have a Functional Mind Facebook page. So and there's definitely some things coming on the horizon. I have an online group coaching program that's going to be launched soon, hopefully.
Very nice.
It's been halted because of COVID and lots of other things. So I'm hoping to be able to provide an online course for people who are interested in working with me in that format. And so you can keep an eye out for that.
Very nice.
I appreciate everything that you do, Nisha. You're really you're a very energetic person. I wish I had your energy, and you're just so giving to the community, and to your colleagues as well as your patients. So we totally need you to continue to do this and educate people about functional medicine and the work that we do. Thank you.
Don't stop. Say something more. Just kidding. Thank you so much. I really appreciate that. And once again, thank you very much for listening to us, and let us know how else we can help you. And thank you so much, Dr. Gina.
Okay. Take care. Have a good night.
You too.